Very good morning to the audience and welcome to this course on Cataract Comorbid Capsule. As all of us are getting more and more proficient in routine cataract surgery, we are encountering more and more cases with certain comorbid conditions, including from the cornea to the retina to uveitis, so on and so forth. So this course is basically designed to try and address those issues as to how we can achieve a good cataract surgery outcome even with cases with some comorbidities. We have a stellar faculty today with Dr. Aditya Sudhalkar and Dr. Shamal Dwivedi, who will be talking to us about uveitis and retina related issues and cataract surgery. We have Dr. Robert Ang, who will be talking to us about how we approach cataract surgery along with cases of angle closure glaucoma or angle closure disease. And Dr. Rajesh Fogla, who will be talking to us about corneal conditions along with cataract surgery, and I'll be ending the course with issues related to silicone oil induced changes in the capsule and cataract surgery. So without wasting further time, I would like to invite our first speaker, Dr. Aditya Sudhalkar, who will be talking to us about tackling the uveitic cataract and the role of steroids perioperative in all forms in cataract surgery.
Yes.
Can we shift to the other podium? Thank you.
Thank you so much, Dr. Shell, and it's an honor to be here for this course. So I'll just start with a quick case illustration. So this was a 55-year-old male, a housewife, who came to us with sudden onset decreased vision and metamorphosis since 15 days, painless in onset. Yeah. She was a known case of diabetes type 2 with fluctuating control and family history of cataract surgery in the mother. The anterior segment examination was unremarkable except for the presence of grade 2 nuclear sclerosis. So this was her photo, and based upon this picture, she had been started on topical nepafenec eye drops, and a presumptive diagnosis of diabetic macular edema was made. The angiographic sequences, however, revealed early hypofluorescence along with patchy late hyperfluorescence, indicative of uveitis or specifically multifocal choroiditis. So these were the, for example, I think I'll just, as you can see, there are multiple patches of choroiditis here. So the patient was treated solely with a dexamethasone implant, and that showed near complete resolution within, say, a week or so of the injection. This was a recurrence that happened about 6 months later, and then a second implant was administered. Subsequently, she underwent cataract surgery, and with a third implant that was for prophylaxis, especially because she had already had 2 recurrences. So this is, uveitic cataract is obviously a technical challenge. We have recurrence, persistent, or new onset cystoid macular edema, epiretinal membrane formation. The incidence complication varies between 12 to 60%, and prophylactic immunosuppressive therapy is now the standard of care. So I would just like to cite our own study and discuss in some detail the entire proceedings. So this is a couple of articles related to uveitic cataract or post-cataract complications such as the Irvine gas syndrome, or what is popularly known as pseudophakic CME. So we have the MUST trial, which validated the use of steroids in, or local steroids, and specifically the intravitreal dexamethasone implant for management of intermediate and posterior uveitis, and to some extent even anterior uveitis. A cheaper alternative is triamcinolone, and 25%, a sample size with a approximate percentage of 25% prevalence and a power of 80%. That was our recruitment criteria, and a 6-month follow-up. So the purpose was to compare the safety and efficacy of intravitreal dexamethasone implant with systemic steroids as prophylaxis in patients with cataracts secondary to or associated with intermediate or posterior uveitis undergoing phacoemulsification with intraocular lens implantation. The trial was sponsored by Allergan India, now of course AbbVie India. So coming to the results, these are the demographic characteristics of both patients in both groups. So the trial was essentially divided into 2 parts. One in which the patient received solely the dexamethasone implant at the time of cataract surgery. In the other group, the patient received oral steroids starting 3 days prior to cataract surgery and extending up to a month after cataract surgery. So if you see, the improvement in vision is comparable in both groups, as you can see here. And most importantly, the cystoid macular edema was controlled in both groups. Most importantly, the dexamethasone implant group did not have any systemic complications. So we concluded that the Dex-I is non-inferior to systemic steroids in the management of uveitic cataracts. It is a good alternative in uncomplicated cataract surgeries, and it is a safe option for local therapy, which is generally preferred, and obviously it avoids systemic. So there are a couple of other articles or publications that we have had with international speakers, and all of them conclude more or less the same thing. The problem with the use of steroids in cataract is that everybody is apprehensive about IOP rise and cataract formation. Now, of course, if cataract surgery is being performed concurrently, one complication is practically eliminated. But as far as IOP rise goes, what we have seen is that as far as the dexamethasone implant is concerned, the IOP can be very well controlled with topical therapy. In a series of about 477 eyes that received dexamethasone implant for various indications, including diabetic macular edema, uveitis, and vein occlusion, only one patient or one eye needed a trabeculectomy. So overall, it is a very safe implant. In a price-sensitive market like India, the problem, of course, is the cost. And so the triamcinolone implant, the triamcinolone acetonide injection works very well. Now, the problem with triamcinolone acetonide, as we know, is persistent and a very steep rise in the intraocular pressure. And it is often, it extends much beyond what we would consider as the duration of efficacy of the injection. That is not the case with the dexamethasone implant. So in the Dex implant, what happens is that even if the IOP does rise, it almost always touches baseline by the end of 6 months, which is the life cycle of the implant. That is not so with triamcinolone. And this is the reason why we, if affordability is not an issue, we prefer the Dex implant. So this is just, our technique of injecting triamcinolone. And this is based on a study that we did, wherein we looked at the position of the Dex implant, and what we saw is that the closer the implant is to the pars ciliara, the higher the chances of an IOP spike. The hypothesis is the entry of the steroid molecule in the anterior chamber is imperative for glaucoma occurrence. That is, the trabecular meshwork changes, increase in glycosaminoglycans and so on and so forth, happen more frequently with anterior position of the implant. Based upon that, what we do is we do a conjunctivotomy, a tenotomy, and then use a viscocannula to actually inject triamcinolone into the subtenon space. So what it does is, it has two advantages. One is where you are, and there is no inadvertent puncture of the sclera during the procedure. This is just a video on how to inject the Dex implant at the end of cataract surgery. So you go in with the bevel down and you aim for the optic disc. So doing that, it helps you, direct the implant as posteriorly as possible. What we also noted is the surgeon removed the dispersive viscoelastic after the injection of the implant. Why dispersive? It will block the ports, the main incision and the side ports well enough, and there will be no squishing of the eyeball, because it's a big needle, it's a 22 gauge needle, and that is what we don't want to do. That is cause collapse of the globe. So again, some articles on the safety of the implant. Overall, it's a very safe procedure, and especially post-cataract, we have rarely, if ever, noted any IOP spikes. This is just from our article, and this patient received the implant. He had a uveitic cataract, and he got the implant prior to cataract surgery. And as you can see, this is flush with the pars plana. So this patient developed an IOP rise within 3 days of injection. So he came to us with an IOP of 37 with vomiting because of the sudden rise in IOP. So this is something that we want to avoid. As you can see, the implant is stuck in the pars plana. This is yet another case, another problem that we have seen with the Dex implant is lack of familiarity with the procedure. And this was a surgeon who actually just punctured the conjunctiva and you can see the whole implant is subconjunctival. So what happens is that everybody's scared of the size of the needle, but just a few procedures and I think everybody's good to go. So the patient here came with a complaint that there has been no change after the injection, and obviously because the implant is not in the right position. So just to conclude that uveitic cataracts can be very readily managed and eminently managed with local therapy. It is a very good and viable alternative to systemic steroids. It can be supplemented with systemic steroids, of course, at any point in time. It lessens the incidence of post-operative systemic complications and even ocular complications. And if not the DEX implant, there are cheaper alternatives available. Thank you very much for your attention.
Thank you so much, Dr. Aditya, for that wonderful presentation. And I think it's very important that if we can avoid any form of systemic complications during an ocular surgery, because that's what patients don't really expect, systemic complications to occur after a topical cataract surgery. I think that would go a long way in, improving our confidence as well in counseling the patients. I had just one question, Dr. Aditya. Because you showed the implant position makes a lot of difference in the intraocular pressure, how do we kind of assure that we are injecting in a proper way? Is it the distance which matters, or the way, the angulation at which you inject that matters?
Right. So I think the biggest rate limiting step, if I may call, is the fluidity of the vitreous. So if it is gel-like, then it will impede the progress of the implant posteriorly. If it is fluid, you might actually end up hitting the retina, and there have been instances of the implant hitting the retina and causing superficial hemorrhages. Some have even reported a break. So in a vitrectomized eye, sudden pressure on the applicator clip should be avoided, but in normal eyes, I think you should go in with full force. So that is one thing. But yes, of course, you can't really have total control over that. And just if I must just take half a minute, what we have seen is that in severe uveitis forms such as say VKH or even sympathetic ophthalmitis, the implant has an independent and often superior role to systemic steroids. So there have been instances where the patient has received, with sympathetic ophthal, has received intravenous methylprednisolone, 3 or 5 doses, and was put on oral systemic steroids thereafter. There was the lumpy bumpy choroid that we associate with, that did not disappear until we put in the DEX implant. So yes, I would rate it in some situations even superior to oral therapy. So.
And how quickly does this DEX implant start working? Because we are being a slow release implant, we are worried that if the early post-operative period after cataract surgery is not covered, then is there any relevance? So
yes, 24 to 72 hours. So I think almost
quick it starts
yes,
acting.
Instantly. And in fact, in patients with pseudophakic CME or Irvine gas, they have been on topical nepafenac or for months, even years after some cases we have injected, and within 4 days there is complete resolution. So just again one more point, it is there's an increasing trend of injecting anti-VEGFs for pseudophakic CME or Irvine gas. So just if you go back to the pathogenesis of the of Irvine gas syndrome, there is no role for anti-VEGF therapy. So it is purely inflammatory, and we have increasingly seen the retinal surgeons recommending anti-VEGF for pseudophakic CME. So that is something that I just wanted to clarify, that it is best to go with steroid, either triamcinolone or dexamethasone.
Thank you so much for that wonderful talk. Now I'd like to invite Dr. Robert Ang, who is going to share with us something that we also face very often, is a shallow chamber or a patient with either pre-existing angle closure glaucoma or angle closure suspect who is now planned for cataract surgery. It's a pleasure to have you, sir.
Thank you for inviting me, and it's a privilege to be part of this instructional course. So my talk is about dealing with angle closure glaucoma and cataract. So I have these financial disclosures to make. So the scenarios, there are 3 possible scenarios when we encounter angle closure. One is the benign primary angle closure, wherein they have narrow, shallow chambers, but nothing has happened yet. The next scenario is when there's an attack already, and they come to you with an attack and with a glaucoma. And the third scenario is they've had an attack or they've had glaucoma for some time. The eye seems quiet, but they're there for cataract surgery. So these 3 scenarios may have a little bit of differences in approach. No? So the primary angle closure, the what we call glaucoma suspect because of narrow angles. They're usually asymptomatic, narrow angle. If you check OCT, visual field, no damage. But you're alarmed because on the slit lamp, you see a very shallow chamber, a Van Herrick sign, and then you might want to do a gonio or an ASOCT to verify because the patient doesn't feel anything. So the patient sometimes doubts what you're telling them because they don't feel anything. No? Now you're there because you're concerned about any possible IOP spike, or if somebody suddenly dilates this eye, then they'll have a glaucoma attack in your clinic. Or when they're in phaco and they're dilated, they will have a glaucoma attack before your surgery. So you're kind of in a tough spot at some point because you want to avoid the disaster. So the options, there are two options actually. One is a YAG, peripheral iridotomy, or an outright phaco. So, studies, papers have been shown. So one of the landmark papers that came out was the Eagle study, wherein they compared, is cataract extraction a good idea for solving angle closure suspects? And of course, this was published in a Lancet, a very big publication. So it showed greater efficacy and more cost effectiveness if you do cataract surgery outright for these patients. But of course, some patients may not want to have cataract surgery, especially if their vision is still good. So there are other studies like the Zongshan study where it shows that even doing peripheral iridotomy is beneficial to tide them over. You know, these patients may not be ready, may not be willing, or may be suspecting that you just want their money. That's why you want phaco, no? Oh, surgery, so they pull back, no? So, but other studies comparing YAG-LI and phaco always show that phaco is better. So phaco is better. There are several publications about the benefits of phaco and prevention of angle closure afterwards. So what are the considerations in approaching these patients? Number one is what is the IOP? If they're low, then you're fine. But if they're like 20, 21, 22, and you document that they were 15 last year, now they're 20, they're 59, 60 years old, or above normal, what do you do? So, option one is to convince them of a YAG-LI, no? And then you document patent LI, AC deeper, then you proceed quietly to a phaco. So that's my preferred approach, right? But usually I will document with an ASOCT so that they see that the angle did open up from a shallow one. But that's another cost. So you have to talk to the patients. Or they don't want a YAG-LI and they want to proceed. So I will give them an eye drop, for example, a Combigan or something like that, a dual acting, just to lower their pressure, even though it's normal, when you get into the cataract surgery. So you're kind of protected until the morning of surgery before you dilate them. Then do a phaco. Since there is no damage to optic nerve, you may proceed with the premium IOL of choice. No? So, standard phaco techniques. If they want femto, of course, it's easier to do a capsulotomy in a shallow chamber if the femto is done. And the long-term prognosis is usually good in these cases. So, the problem is when they go into an attack. So, when they go into attack, the acute phase is the most difficult time because they have pain, blurry vision, redness, headache, the patient's panicking, distressed, and then when you see them, microcystic edema, frozen pupil. The cataract may not be dense at this time, but the AC is shallow, and usually it's very high, 40, 45, 50 IOP. So your goal, if you see them the first time, is to break the attack. Break the attack meaning pour everything in, all the glaucoma category of medications. I do oral acetazolamide, 2 tablets right away, and then 3 times a day for the next 3 days. And then once I see that the pupil might react with pilocarpid, I will attempt a YAG-LI on these patients. so that I have something before I go into surgery, and a mild steroid to quiet the eye. Most of the time, these maneuvers with the help of your glaucoma doctor will be successful in controlling the attack. So once stabilized, you have to keep the IOP controlled with all the medications, no? Now, what are your considerations going to surgery? Number one is your IOL calculation. You have a edematous cornea, shallow chamber, so you're not sure about your biometry and you're not sure about your optic nerve status. So if there's an attack, I usually will tell them, let's just stay with a monofocal IOL or a monofocal toric. You have to be ready with the pupil maneuvers because they usually have a fixed pupil. So they may not dilate more than the mid dilation, or they may be, if longer, they may look atrophied, fixed, and all that. So these are considerations to prepare for during surgery, and you want to be ready. Now, how to approach these patients? On the day of surgery, I will give routine mannitol. So I get a cardio clearance. I will always sedate the patient. And we do a retrobulbar anesthesia, even though it's just phaco with hynidase. And then I was taught in residency to put a lot of pressure. It's like you're mushing the eye, right? It's like you're squeezing the eye. No? We do that with corneal transplants too, right? We squeeze the eye so that you squeeze a little bit of pressure out of the eye. You may or may still not have a edematous cornea, and there was once where I had to de-epithelialize the corneal epithelium just to see what I'm doing. You want to decompress the lens if they're phacomorphic. There are papers, and we've done this in residency but not in private, where I had a retina fellow do a little bit of anterior vitrectomy or aspiration behind the lens. I didn't want to do it, but a retina fellow helped me do it. Now, one thing about the angle closure, sometimes they have a weird feel when you do a capsulotomy. I don't know if you feel that they don't tear as, they're not as robust in tearing, so they can extend out. And I've had several cases where the zonules were affected by the very high pressure. So we have to be very careful with this. I usually tap a little bit in the slit lamp to see if the lens is moving. But during phaco, sometimes you groove and you're pushing and then the lens is moving. So you kind of want to be careful. Adjust your technique for a shallow AC. At the end of near the end of it, in my last chunk, that's when I'm most afraid of high vit pressure. So I have a blunt instrument to protect it. And at the last parts of the surgery, I will usually relax the speculum. No? Relax the speculum so that you don't additionally push the eye. So these are all for high pressure. So options for these are trab only. So if my IOP is still 40, 45, 50, and all of these do not work, I have a backup plan where I tell the patient, we have to stage the surgery. We trab first, and then maybe after a month or two, when the trab is functioning, do the phaco later. If you control the pressure to below 25, I proceed with a phaco combined. So most of the time, I will do a goniotomy or GSL, but I'll show a video later of a MIGS with a phaco. And then you can do a phaco trab if really the pressure is high, you were able to do it, but the patient cannot afford a MIGS, then the trab is cheaper. So the factors affecting your decision are, number one, if you were able to control the IOP quickly, then there's a good chance that the TM is still functioning. No? So you might just need to do a phaco. But if still uncontrolled and very high, then you kind of need to find a way to solve this synechia. So the gonioscopic status is important, and your estimation of IOP after surgery is important. So this video is a phacomorphic, and I just want to show that I puncture after I do vision blue, I puncture and then I suck a lot of the milky cataract, just to decompress because this happened to me before that I extended when I punctured and then went out, no? And then it was a bad case after that. So decompressing, putting gel, and then even if the white materials oozing out of your wound, but you're able to complete a capsulotomy. So it's easy if your capsulotomy is intact. So another maneuver that I do is if I feel that if the pupil is frozen, no, at the end of the case, I will usually do this. I would pull the iris towards the middles with my IA, so that it's like peeling your PAS in a certain part. So I try to pull it because I think that the goniosiniculitis just pushing it is not enough. So I just pull and tear it away from the angles. No? So chronic angle closure is actually more common than angle closure attack because somebody has probably solved the attack and they come to you later for the cataract surgery, maybe months or years after. So the course of action depends on how severe the cataract is. So the pupil may be atrophied, so I do that pulling maneuver. You may have synechia on the pupil or on the angles, so you have to deal with that. And then avoid usually a multifocal because of the compromise in optic nerve. And your conjunctival status might be cooked because of prolonged meds. So combinations of surgeries, again, I would probably combine it with glaucoma surgery with phaco. And these are studies saying that actually more studies are saying that phaco only is good. Don't combine with anything. So, but then these are probably expert doctors, but you're on your own, so you want to do something in addition. So, I did a study on chronic angle closure glaucoma with a MIGS, a hydrus, and as you can see here on the left column, pre-op, many are on 1, 2, or 3 meds, but post-op at 12 months, only one patient had one med. So it is actually very rewarding to put some MIGS in this kind of patients. So this is a video of, So I do after the phaco, I do the phaco first to open the angle, and then if there's still some synechia, I would do some of this GSL, goniosiniculitis. I would open just maybe 1 to 2 clock hours so that it's visible enough that I see the scleral spur. I have to identify the TM, and then I would put this hydrus. No? The hydrus is now owned by Alcon. So Alcon will release this, and it's a long stent or MIGS. And you see that if you test it with vision blue, you will see that there's a leak in the conjunctival vessel. So if you test it, you will see that, it's patent, and it's working. So in these patients, patients initially were all closed, half or 360 degrees closed. And then at the end of 12 months, maybe more than 80-90% are less than half closed. Still some areas of closure because I did not do GSL all over, no? But it helps. And then if you see the angle, so this is the reason why the hydrus is what I like for angle closure is it's like a straw, the part of it is jutting out of the anterior chamber. And even if later on you see that some of the areas are becoming synechia again, no? The pupil creeps up, and even if you do GSL, it will close again because of the hydrus jutting out. It still drains fluid behind the TM. So this is like 360 degree closed again, but since this is open, the inlet, then it kind of drains fluid. So in summary, controlled IOP prior to surgery makes your life easier. So we do gonio. Most doctors don't like to do gonio, but you have to do gonio at least pre-op. Adjust technical difficulties, adjust your IOL choice depending on the damage, and monitor the patients post-op. Thank you.
Thank you so much for that excellent, comprehensive overview of managing all different variations of angle closure along with cataract surgery. I had a couple of questions. One is, say if it's a angle closure suspect, you haven't done a PI, patient has agreed for cataract surgery, IOP is borderline. So in such, and you have generally you avoid dilating them except on the day of surgery. So on the day of surgery, even if there is no angle closure attack or previously, would you still consider giving a mannitol before dilating them?
Yes, yes. I would. So I would do first. They probably will be on eye drops, even the morning of the surgery, because anything that you can do to decompress the posterior is good, because that can go up to you during surgery. And I usually will do, once medically cleared, I will usually give like 100 cc to these patients, just for my peace of mind during surgery.
Absolutely. And the second question is that particularly when the patient has had an attack and has a fixed pupil, say around 4.5 millimeters, at the end of surgery, would you consider, making the pupil smaller with some form of pupil repair, pupilloplasty, or you find that?
Yeah, the pupilloplasty is a tricky question, because you want to be able to see the posterior and test the visual field. If you fix the pupil somehow, then you cannot check the visual field after. So leaving them a little more dilated, that's why I do that maneuver, just to push. But I would rather leave them a little more dilated than constricted for monitoring purposes. That's why you want to put just a monofocal IOL.
Okay. Thank you so much. Thank you so much. Next, it's my pleasure to invite Dr. Rajesh Fogla sir, who's been kind enough to consent to be a part of this course for the past few years. And each year we learn something so beautiful and something very practical from our management point of view. And he's our go-to person if anything goes wrong in the cornea. We make a phone call, and he's been very kind to help us out. So thank you so much, sir, for once again being a part of the course.
Thank you, Shail, for the kind introduction and making me part of your course. And it's always a pleasure to participate. And today, usually I speak about endothelial problems and cataract surgery. So this time the topic was changed, and Shail said, okay, I got bored of listening about endothelial keratoplasty. Let's see what you do when you deal with a corneal opacity and a cataract. So So I'll be giving an overview on how to manage this scenario. I don't have any financial interest to disclose. Now, cataract surgery definitely poses a challenge when there is a corneal opacity. And in this scenario, I think there's the importance of advanced imaging techniques. You have to modify your surgical technique and the post-op management. And you have to try and optimize the visual outcome despite the patient having a corneal pathology. So basically, it's trying to bypass any corneal surgery and still address the issue of dealing with the cataract and trying to improve the patient's visual acuity. Compared to cataract, which account for 51% of global blindness, corneal opacity is much lower, only about 5%. The challenges when you have a corneal opacity are the poor visualization, the induced high astigmatism, and sometimes there can be increased risk of complication because the visual acuity is not good. So why do you get the corneal opacity? Commonly we see post-corneal infections or trauma. Rarely in older patients, they will come with degeneration. Most commonly you'll see the spheroidal degeneration that happens. And in people who are from the Middle East or the equatorial belt, the chronic trachoma also induces a kind of haze. And patients usually, they stay on till they develop advanced cataract, so they don't come back. And then when you go and look at it, you find that, yes, it's difficult. Rarely we see with stromal dystrophies as well, like granular dystrophy or macular or lattice dystrophy, where when there are clear spaces, patients still can manage, but later on when they develop cataract, and to do a cataract through that corneal dystrophy is sometimes a bit challenging. And also if you have had post-refractive surgery complication like a haze, or if you have done a DALK and there is a corneal haze, then also addressing the cataract can be a problem. So examine the patient on slit lamp, look at the depth of and the density of the opacity. And for me, I think the location of opacity is important. we do a topography and find out if your cornea is regular or irregular. Because if the cornea is highly irregular, you will have problem with calculating the lens power that you're going to put. But having said that, sometimes we see patients who have been wearing contact lenses before when they had an irregular cornea, and they just develop a cataract. So there is no need to, the patient can undergo a cataract surgery, and you can still go back and wear a rigid contact lens and still maintain good vision. Anterior segment OCT is good because you can see in cross section how deep the opacity goes, and to evaluate the endothelial health, if possible, we do a specular microscopy. Otherwise, we use pachymetry as a indirect way of telling us whether the endothelium is working good or not, because if your corneal thickness is beyond 600, you know that the endothelium may not be working very good. And the other thing is, even in these kind of cases, you need to have some idea about what's the visual potential in that eye, because your patient is coming back. So these devices like the potential acuity meter, where you project a very small image into the retina, you have into the posterior part of the eye. You can get some readings and you can determine what's the visual potential. Because if the patient's eye is amblyopic or not, patient did not have great vision, then there's no point going through the entire exercise. And depending on the astigmatism, regular or irregular, you can think about whether you want to put a toric IOL or not. Usually, in most of the cases, we prefer monofocal IOL. In complex cases, sometimes you may have to fix a scleral fixated IOL when, besides the opacity, if the integrity of the capsule is compromised, or when you remove the cataract, if the support is not adequate, you can put a scleral fixated, or if the iris is adequate, you can even think about a retro-iris fixation of the IOL. And you can also do it as a two-stage. That means the first stage, you just remove the cataract, evaluate the eye, do a proper IOL power calculation, and then come back and do a secondary IOL at a later date. So what do you do surgically? I have some videos, but for some reason, I think there is a glitch in the computer, so the videos are not integrating with the presentation. So we use trypan blue for enhanced visualization during capsulorhexis. You also put, viscoelastic on the corneal surface like methyl cellulose, that also enhances. There have been situations where I have even put a soft contact lens or RGP lens. I put viscoelastic and then I put the contact lens on the surface, and even through that corneal haze, suddenly I find that my visualization is better because the front surface becomes very smooth. And having good retroillumination is also great. You can use even chandelier or light pipe illumination. So having that, like a forced red glow, you can call it, when you put a chandelier. Or if you use a light pipe, you switch off the microscope light and use the tangential light to try and get that. So chandelier, for people who are not aware, is a fiber optic source. So it's like when your retinal surgeon is doing the surgery, he's having a light pipe in one hand and the vitrectomy cutter in the other hand, and the infusion is coming. So that helps them see. But if you want both your hands to be free to do membrane peeling or dissection, something, so you can fix the light just like you fix your infusion cannula. You can fix in a light there and then continue with the surgery. So same thing can be done with the cataract surgery as well. If you have blast injury, a lot of foreign bodies on the cornea, and those kind of scenarios where a direct visualization is difficult, if you put a retroillumination with the chandelier, you will find that the red glow that you get enhanced makes it very easy for you to do the surgery. Just imagine that if you do your routine cataract surgery and you did not have a red glow, how difficult the surgery would be. But the moment you have a red glow, your confidence increases. You can see the capsule, you can see the fragments very well. So I think this is where you do need a little bit of these devices when you do the surgery. Often you will have poor dilatation, especially because of some synechia. So you need to have devices. Either you can put a Malyugin ring, or commonly we use the hooks. I would recommend that whenever you embark on doing this surgery, have both the iris hooks and the capsular hooks. Because there are times where not only do you stretch the iris, but if you want to support the capsule because there is some, zonular loss or something, then putting in the capsular hook is also great. And be prepared for capsular tension ring, the segments, because whenever you go in a complicated scenario, you cannot evaluate pre-op, then these things can happen. And on table, suddenly you realize that, I don't have it. Then it can compromise the outcome of the surgery. What do you do different in phaco? You go slow, just like you go with compromise. And you take into account that there is a corneal scar, so there must be some problem with the endothelium as well. So use low flow techniques, go slow. I would say that in most of these cases, I don't do them under topical. I would give them a peribulbar block and then do the surgery, so that the patient is more comfortable and surgeon is also more comfortable. Use a soft shell technique where you put in a dispersive and then a cohesive. try to use a chopping technique. So you try to minimize the amount of phaco power that you use, and use viscoelastic liberally. Don't try to put your phaco probe in and try to finish the entire surgery at one go and come out. So take your time, you can go back. And for cortical removal, you need to have access from different quadrants. So using a bimanual is always a great option in this rather than going with a coaxial, because that does not give you better access and the control is also not too great. And rarely, if you feel a phaco is not possible, don't persist with it. Sometimes doing ECC or an MICS is equally good, especially if you are dealing with a hard cataract. And visualization is not good. It's better not to lose the cataract in the vitreous, because if you lose and the corneal visualization is not great, it creates a challenge for the retinal surgeon also, and then you have to put in a temporary K-Pro and then you have to do a corneal surgery as well. So a triple procedure, or when do you do a combined corneal surgery? When the opacity is very dense or already the endothelial function is compromised, then I think it's better that you go ahead, combine the surgery. There have been instances where if the cataract is early and not too dense, you can do the corneal surgery first, wait for the the readings to stabilize, and then do the cataract surgery at a later date. Post-operatively, definitely you will need steroids to control inflammation, because the inflammation is slightly more than in other cases. You may need to use sodium chloride, because if you have any corneal edema and if there is any residual astigmatism, patients may still have to wear RGP contact lenses. You can also go back and do topo-guided PRK at a later date for any residual refractive error to smoothen the surface. And as I mentioned earlier, that you can either do secondary IOL, or sometimes you can go back and do piggyback. You can always put a sulcoflex and try to correct. Or people have even are recommending you can put even a toric ICL for any residual astigmatism or anything if it is significant and if you have had an error in the, rather than going back and trying to exchange the IOL, which may sometimes be difficult. Outcomes, it depends on the severity of the opacity and the surgical technique. If it's a mild opacity, most patients can still see 20/40 or better. So I think in conclusion, I think the pre-op investigations, imaging and planning the outcome is important. Don't put it in your routine list and try to do that. See the case, examine, plan, discuss with the patient the surgical complications that can happen and the need for a subsequent procedure. Intra-op visualization technique, so acquire the light pipe or the chandelier illumination, and I think individualized treatments will definitely give you good outcome, because if your patient has been seeing well despite the corneal opacity before he developed the cataract, then the goal is to restore the vision back to the same level. So this is in short an overview about dealing with corneal opacity and cataract. Thank you for your patient hearing.
Thank you so much, sir. So I had a couple of questions.
Yes.
One is patients who have had this corneal opacity due to, say, recurrent viral keratitis.
Yes.
So it's been, if the eye has been quiet for a year and a half, they are not on any antivirals or so. But before planning cataract surgery, would you restart them? Or
we will restart, because what happens is when you do the surgery, the surgical stress and the use of topical steroids in the post-op increases the risk of a recurrence of the viral keratitis. So I would at least maybe 1 to 3 months before, I will start them on oral prophylaxis and then continue with that. And if anybody has difficulty in taking oral prophylaxis, topical ganciclovir ointment is available with us. So we can start that thrice a day, and that also gives some amount of protection preventing that. You can even add it in your post-op regime and continue with that till the time the patient is on steroids.
Okay. And sir, quite often we have some of these patients with corneal opacities have some adherent leukomas in the mid-periphery to periphery. So if the rest of the pupil is dilating and if you are able to go ahead with cataract surgery, would you still recommend removing that adherent leukoma for the cornea? Or
again, it's again depends on the extent of the adherence. If it's just a focal adherence or something, since you are going inside the eye, you can always go with the scissors and snip it off. But if it's a broad adhesion, where by trying to remove it you will induce more pigment release, inflammation, then I don't see, as long as it does not interfere with your surgery and you can do your surgery well, I think you can just leave it, because you don't want a new problem to happen. Because when you release that, and if the iris is, you don't have a pupil, sometimes the synechiae will recur and they may be worse than what you started with.
off with. Thank you, sir. Thank you once again for that wonderful talk. Now we have Dr. Shamal Trivedi, who is part of our retinal team at Raghudeep Eye Hospital, and he'll be sharing with us something which is very, very important, something which we encounter in, at least in our part of the world in Gujarat. 6 out of 10 patients are diabetic who come for cataract surgery. So he's going to share with us the pearls of managing cataract and diabetic retinopathy. Yeah. Can we have this podium on the screen, please?
Good morning everyone, and thank you Dr. Shail to give me an opportunity. So these are our financial disclosures, and I'll be discussing how to deal with diabetic macular edema along with the cataract. So as we all know that India is set to be a diabetic capital by 2030, and we all are aware about all the dreaded complications which it can give. And the most dreaded complication on the top of the list is the vision loss. So that is the reason we are very, very aggressive in managing diabetic macular edema. So let us discuss how cataract and diabetic macular edema can be managed. So there are two ways to do it. The first is the targeted macular treatment, that is the drying out the macula first by giving appropriate intravitreal injections or lasers, and once it is dry for some amount of time, I mean maybe 2-3 months or so, then we can proceed with the cataract surgery. And the other way is treating the cataract and the diabetic macular edema together with appropriate intravitreal injections, and which is known as the combined approach, and we are currently interested and our lecture is based on that. So these are some common indications, and we would not go into much theoretical details, and it's already proved that diabetic macular edema worsens in diabetic patients undergoing cataract surgery, and thus managing it efficiently remains our primary goal. So this slide is self-explanatory, but the main thing what I want to focus is the gonioscopy to rule out the neovascularization. You may get away with any injections you give, but if you give a steroid implant in a patients with proliferative diabetic retinopathy, then you can be in trouble. So the main thing to emphasize is to rule out the neovascularization in the angles, and as our friends already told that we don't like to do gonioscopy much, so it is very imperative to join hands with a glaucoma colleague so that we can proceed in a proper way. So again, we are not going into the theory part, and as most of you are aware about the DME management options, out of which intravitreal injections are the most popular and widely used modality of treatment. So let us see some real world scenarios now, and our team was also involved in the trials related to the dexamethasone implant, and it has been concluded that dexamethasone implant is a valid treatment option in patients with diabetic macular edema in treatment naive eyes. So here is our first case showcasing a cataract and a diabetic macular edema secondary to non-proliferative diabetic retinopathy. The patient successfully underwent a phacoemulsification along with the dexamethasone implant, and even at the end of 3 months, the patient continued to maintain a decent visual acuity and almost regressed diabetic macular edema even post many months. So let's go with the case 2, and this gentleman is a one-eyed patient. He has an inoperable TRD in the right eye with no PL, and this is the left eye is the only seeing eye, and he has a diabetic macular edema with a significant cataract. So this is a surgical video of the same patient undergoing a phacoemulsification and IOL implantation. So once the IOL implantation is done, dexamethasone implant is injected by a 2-planar entry, usually 3.5 mm from the limbus as seen in the picture. So now I would like to emphasize that my technique to go for the intravitreal injection is to go to the opposite side of the main incision so that you don't open up the port. Yes, we do have viscoelastics in place, but still to be on a safer side, it is better to go on the opposite side of the incision so that you don't press the posterior lip and open the incision and the AC wouldn't get shallow. So further seeing, so the direction of the needle once in the globe, it is directed towards the center of the globe. It is very, very essential to view the implant in the vitreous cavity as we see right now, confirming that the implant is in place and it is going into the posterior cavity. So this is again the post-operative result, and it is very satisfying to see the excellent visual recovery. So this particular patient underwent a focal and a grid laser, and you can very well see the first picture over here is the pre-focal laser picture, and the next picture is the post-focal laser. We can see the regression of hard exudates in this picture, and the patient is still managing quite well without the need of any further injections. So let us proceed to the third scenario. So this patient is almost looking like a normal patient with a normal fundus appearance in our OPD, and this patient was posted for a cataract surgery. But as we have a very stringent pre-operative measurements, the patient underwent an OCT, and we were surprised to find that the patient is harboring a diabetic macular edema not only in the right eye but also in the left eye. However, the right eye was posted for the cataract surgery, but the OCT has totally a different story to tell. So this was a little older patient, and the patient was subjected to fundus fluorescent angiography to know that what is exactly causing this diabetic macular edema, or maybe it is it a diabetic macular edema, or is it something to do with the uveitis. So the patient was subjected to a fundus fluorescent angiography and to identify the reason of the macular edema, which demonstrated that it is a non-proliferative diabetic retinopathy with a macular edema. So again, the patient was subjected to the cataract surgery with dexamethasone implant, which proved very fruitful to the patient regaining a full visual acuity. So again, this is a case, the next case, and this is obviously looking a very bad looking fundus. And if you see in the right side of your left side of your screen, we are able to see that this is a vitreous hemorrhage and lots of hard exudates and lots of cotton wool spots. So this indicates that this is a patient of a proliferative diabetic retinopathy, and this patient also has a massive diabetic macular edema. It is very essential to note that the patient is having some signs of disorganization of the inner retinal layers, especially in the right eye, which is again suggestive of ischemic macula, while the left eye looks pretty much okay. So this patient was subjected to the OCT angiography, which we have in our clinic nowadays, and we were surprised to see that, not surprised actually, we were expecting this. We can see very beautifully neovascularization on the disc, neovascularization elsewhere just near to the disc, and even this picture not very clear, but still we are able to recognize those fine vessels on the disc. If we go further and if we see, this patient was subjected to an intravitreal anti-VEGF injections, because this is a proliferative diabetic retinopathy case, and we are not supposed to give steroid injection unless the patient has undergone a PRP. So this patient underwent right eye and the left eye injections of an anti-VEGF, but even we could see a very nice resolution of the macular edema, but the OCT angiography shows a large non-capillary perfusion areas, and this patient needs a very, very aggressive pan-retinal photocoagulation even after the cataract surgery, which has to be monitored regularly. And such type of patient, in spite of giving so many injections and PRP, they may still go into a neovascular glaucoma phase. So they have to be monitored with extreme care. So this is a case of one more case, and in this patient we are able to see a diabetic macular edema with a vitromacular traction. So usually the the vitreous is very, very sticky in patients with diabetic patients, and over here it has caused a diabetic macular edema. So in this patient, after the cataract surgery, we were forced to go in for a pars plana vitrectomy. And in this case, we need to see that triamcinolone acts as a very good vehicle to remove the vitreous which was adherent to the retina. So once the vitreous is recognized, we had to use a triamcinolone to do an internal limiting membrane peel, and with which we are 100% sure that the vitromacular traction was totally removed, and this was done with the use of a brilliant blue dye. So once it was completed, we augmented the patient with some more pan-retinal photocoagulation, and that was the end of the case. And we are very happy to see a stellar response with almost resolved diabetic macular edema and restoration of the normal foveal contour. So this is the final case, and this case is very close to my heart, and he is a young photographer and a young diabetic and having all sorts of diabetic complications. So he presented with this picture, both the eye having diabetic macular edema, with left eye having a subhyaloid hemorrhage. So as the OCT showed a massive diabetic macular edema with a taut posterior hyaloid in the right eye and the epiretinal membrane in the left eye. So this patient was subjected to different intravitreal injections in both the eyes, and patient has received multiple injections. However, right eye refused to give any response, while left eye started responding well. So we had to make the patient undergo a vitrectomy in this case, and so after a successful phaco and in the bag IOL implantation, a 25 gauge vitrectomy ports were constructed. So as he is a young diabetic, the vitreous tends to be very adherent, and at one point of time I was feeling that why did I take this case, because I was not able to achieve a PD in spite of trying very hard for a very long time. And at one point of time I thought, let me just abort this case, but I was quite lucky that I kept on trying, and at one point of time I was able to achieve a posterior vitreous detachment very nicely, as right now evident on the screen. So this is the V's ring which I have created, and I don't want to do anything more for this patient. We just need to do a PVD induction, and that is usually the end of the surgery. Of course, because this is a patient with a proliferative diabetic retinopathy, it goes without saying that we need to do a pan-retinal photocoagulation. So after that, that is the end of the surgery, and it was extremely satisfying to see a complete resolution of the macular edema, though there was some foveal thinning, but this patient never required any further treatment, and we have 2 years follow-up of this particular patient, and he is doing extremely fine, and he has also regained all his photography activities and his job. So it is very essential to identify the correct diabetic retinopathy stage and make patient understand about their own conditions, as diabetic retinopathy is a very complex disease. So now the time has come where we need to join hands with a retinal colleague for a better customized approach for the patient. And last but not the least, dexamethasone implant is an excellent choice for patient undergoing cataract surgery with diabetic macular edema in most of the treatment naive eyes after proper evaluation of the retinopathy status. So these are some futures in the diabetic retinopathy which are still going on, still not out. So most of the things are usually focusing on the underlying edema. So the main thing in the diabetic patients is the edema, and these are all the newer things which are targeting this. So thank you very much for your attention and engagement throughout the presentation.
Thank you so much, Shamal, for showing that entire basket and variety of cases, right from medical to surgical. But I think the most important take-home message is that we must involve our retinal colleague before planning a cataract surgery in a patient who has even the mildest of diabetic retinopathy, because quite often we may find the foveal contour is okay on OCT, but they may have some new vessels which have developed in the periphery which we may have missed in looking at the cataract. So always get a retinal surgeon opinion done pre-operatively and forewarn these patients that you are likely to have slower vision recovery, you are likely to have macular edema post-operatively even with the best possible cataract surgery and the best intraocular lens. So you'll need to follow up with the retinal surgeon post-operatively also, and if they know beforehand, they will be more ready to accept it post-operatively as well. But thank you so much.
So there is one more observation, that if a patient comes into your OPD and he is having some kind of retinopathy but not a diabetic macular edema, but the presence of ERM is very important. If that patient has just a presence of ERM, the amount of patient developing macular edema or diabetic macular edema is almost 4 to 5 folds. So if you see an ERM with a diabetic retinopathy, it's a warning sign. So sir, as a retinal surgeon, I would always prefer that it should be a monofocal lens, so that the retinal surgeons can have a good view of the retina whenever required. But however, I think Dr. Shail or the other faculties may have a better outcome.
If there is a significant macular involvement or any form of new vessels or something, I think a monofocal or a monofocal toric is the best option. Whatever the patient says, we have to kind of put our foot down on those occasions. So I'll be sharing some of the things that we find useful. Yeah, sure.
Any complex of these IOL and the whatever you heard?
Usually, if the prognosis, we would do a potential acuity test, and if the prognosis is good, maybe up to an EDOF right now, but maybe not a multifocal. We're really afraid of causing more harm than good. Even she's right. Even if they're insistent, we have to say this is not for your eye.
Okay.
But I think the potential acuity vision that you're measuring pre-operatively, we used to do that. We don't do it anymore now, actually speaking, in reality. So it's a good idea, actually. I like that to get some understanding. What is the potential? Some bad maculas may have a good vision, you will be surprised.
Actually, the potential acuity sometimes is more important for us to manage the expectation that this is as far as it will go, rather than choosing because, oh, even with this, all the tests, we think that this is as far as you can go. So that way, the patient doesn't over-expect us to deliver more than what the disease has.
And if it's a good acuity, I won't tell the patient that it's good. That's another trick I use.
So these days we are facing this problem because patients go on the internet,
Yes.
use ChatGPT or something, and they are more knowledgeable than us. They come and say, I want this lens, I want this lens, and then you spend so much of time trying to explain that like the presence of a problem or something that can evolve over a period of time. It may not be there at that point of time of surgery.
Yeah.
But let's say after 3 months or 6 months, but then the brain goes on to your surgery.
Surgery,
and the choice of
yeah,
lens, so you
absolutely.
wouldn't want that to.
Correct. Absolutely. Very true. So we do receive research grant support from Alcon Laboratories, but has no relevance to this presentation. So this is quite common for us as cataract surgeons. Perfect, beautiful retinal surgery done, silicone oil also sometimes removed, not removed, been there for 6 months, year or so. And the patient is then referred for cataract surgery. And this is at the end of lens removal. You find these very, very dense, thick plaques. And in spite of whatever you do, whatever irrigation, aspiration, polishing, these just don't get released. So these are very thick fibrous plaques, and quite often quite a lot of them are stuck even on the posterior part of the posterior capsule. And very often these plaques are so thick that they are very, very difficult to even laser them post-operatively with YAG. They just don't break. And therefore whatever the potential acuity the patient has is not achieved. Again, you can see this sheen, which is suggestive of silicone oil still behind the posterior capsule, but this very, very dense, thick plaque. So even if you do a perfect cataract surgery in the bag IOL implantation, if your central visual axis is not clear, whatever that visual acuity the patient is likely to have is not going to be achieved. And particularly if the silicone oil is going to be in there, that becomes even a more problem. So the easiest way that retinal surgeons have taught us is that you put the IOL in the bag, and if the silicone oil removal is to be combined with cataract surgery, and then don't worry about it, we'll go in with our capsulotomy, with our vitrector, and do a capsulectomy post the IOL implantations. That's the safest way. So we went ahead with that plan. This was a very high myope for whom the RD surgery was done, and therefore the power was so low that it required a 3-piece IOL. And once the retinal surgeon has done the silicone oil removal, the plan was to do a nice central capsulectomy with the cutter so that the visual axis remains clear. And things are going off quite okay. They use a relatively lower cut rate to make sure that the cut is being done instead of a high cut rate when the plaque is thick. And this case was being closed, the trocar is removed, and you can notice here that the tear, the capsulectomy is actually extended. So this can occur particularly in fibrous capsules when you are using a vitrector, that the opening doesn't always become predictable, and like in this case, it extended not only in the center but a very huge extension right up to the equator. So this IOL is obviously not going to stay stable inside the capsular bag, and we thought of prolapsing it in front, since this was a 3-piece, and put it in the sulcus. But before anything else could be done, the IOL decided to say bye-bye to us. So We had to call the retinal surgeon back again, trocars were put again, IOL was brought out, so on and so forth, lying on the retina. So having learnt from that case that maybe capsulectomy may not be the best idea in cases with a thick posterior capsular plaque, we come to this second case of a cataract with emulsified silicone oil in the anterior chamber, half of it there, and the patient is now planned for a cataract surgery along with silicone oil removal. So cataract surgery goes off well, and you can notice this very dense and dirty plaque on the posterior capsule, which is very thick. So I'm not going to place the IOL now, having learned from the previous case. So I'm just forming the chamber with viscoelastic. Then I'm going ahead with my retinal colleague to make sure that we remove the silicone oil from behind the eye. And then my first plan at the moment is to try and create an opening in the posterior capsule by attempting a plaque peeling, or if required, a posterior capsulorhexis. So having realized that this plaque is so stuck to the posterior capsule, there is no way to create a plane in it. So since the silicone oil is removed, I am not worried about silicone oil prolapsing in the anterior chamber. So I am going ahead and trying to convert this opening into a posterior capsulorhexis, which will act as a strong margin. Now, quite often these plaques can be very difficult, can be very tenacious, and you may need to even cut it with scissors, and therefore it's important not to place the IOL in the bag at this point of time, so that I have the option of the sulcus placement of 3-piece IOL if this capsulorhexis goes awry. So I'm going ahead, trying with all my might to convert it, going from one side port to the other, going from one incision to the other, approaching it from different areas, so that my ergonomics is well maintained. The angulations or the forces in trying to cover this plaque all around work quite well. And you do need special instrumentation like these micro incision capsulorhexis forceps. And fortunately, we were able to kind of create a good central visual axis opening in this patient with this dense silicone oil plaque. Now, since you have created that opening, it's a strong margin. So therefore, you can go ahead with your planned choice of single piece IOL in the capsular bag. And this visual axis is now not going to opacify come what may. And whatever that visual potential may be will be achieved right from the early post-operative period. So this is the posterior capsulorhexis that was done, and this visual axis is going to remain clear. Now coming back to that first case with this dense posterior capsular plaque and these thick folds that you see with this plaque in the center, we tried polishing, we tried rubbing the capsule, we tried everything, but nothing worked. So in this case, it was such a deep chamber that I was worried that if I put more viscoelastic, I might not be able to even reach the posterior capsule. So I have put an anterior chamber maintainer and attempted to first try and see if I can find a plane between the capsule and the plaque, which was not possible. And therefore, I've created an opening in the posterior capsule and then trying to convert or circumvent the at least central plaque area, this large plaque area. So that if I can at least circumvent this, at least the visual axis will be clear. And I know if I end up going wrong, I still have a good anterior capsulorhexis on which I can place a 3-piece IOL and then capture it through the anterior capsulorhexis. So it's important that you attempt this maneuver before placing the IOL. And fortunately, again, we were able to create a large enough central visual axis opening which would be useful for this patient. And if you have a good capsulorhexis with strong margins, you can consider going ahead with in the bag IOL implantation because this posterior capsulorhexis is now not going to split even during maneuvering or even during removal of your irrigation aspiration. So you go ahead normally, remove the viscoelastic, that was little bit of viscoelastic that was there in the front, and this large opening that you see is the posterior capsulorhexis. And once again, although the visual potential in these cases may not be very great, but whatever that visual potential is likely to be achieved right from the early on period. And you can notice the rest of the capsule being very thick, very fibrous all around. So I think silicone oil plaques quite often, particularly if they've been long standing, if the silicone oil has been in the eye for a year, 2 or 3, which they do in some high risk cases, they need to be attempted to be treated surgically. The most important prerequisite is that the silicone oil has to have been removed either pre-surgery or during surgery. From our learnings, what we have found is that doing a posterior capsulorhexis is far better compared to doing a capsulectomy with a cutter, because it's more controlled, and since you're doing it before the IOL implantation, you always have plan B, that if things don't go off well, you still have the option of a 3-piece IOL in the sulcus, and discuss with the patient that because your eye is complicated, we may have to change our plan of IOL choice or IOL type intraoperatively based on how things go surgically. So thank you so much for the patient listening, and I would value Dr. Ang's comments and Dr. Fogla's comments on how you would approach these cases with silicone oil plaques.
Very nicely done. It's very sticky, as you said, and the retina doctor has to be sitting beside you, so to save you anytime. But very nice. I'd probably do sulcus if it's not that thick, or something, just to be sure. And but everything else seems to be fine. Dr. Fogla?
I think most of the point is covered very well. But like I said, that you prepared with a 3-piece IOL, because if you have a regular single-piece lens, and that's not supposed to be put in the sulcus. So that should not be the situation that you didn't have a choice, because if you put the lens in the sulcus, which has a square edge happening, you may have a prolonged uveitis that may present. So and the 3-piece also allows a better optic capture as well, because the haptic is, the design is such that you can capture the optic.
We encountered this with a patient with ICL, had retinal detachment because high myo, then had silicone oil, developed the cataract, then this is like the 4th surgery. So we have to go in and out as fast as possible. Sometimes there's some residual oil. So
Yes, absolutely.
yeah, sometimes it's residual oil that you don't see, or some vacuoles, right,
Yes.
moving there. No? Do you?
Most of these complex cases, we always keep a intraocular forceps in our regular tray, because like what you said, that if you have a lens that's sinking, you immediately need that forceps to go in and
Grab it, yeah, absolutely.
before the lens by the time you ask for it and they get it.
Yeah.
It's already gone, absolutely.
Just wanted to find out, Otillie has that radio frequency probe to do the capsule.
Capsule, right,
corrections for the
yeah.
anterior. Would
Yeah.
that work in these kind of scenarios when you have a posterior fibrotic, that you could go with that and make a...
Yeah, Suresh Pandey, who worked with Dr. Apple, has shown many techniques of doing this plaque stuff. It doesn't work very predictably like a manual. It doesn't give the strength every time, like a retractor. Even if you use the fastest cut rate and the radio frequency, it's not very predictable or consistent. So if you have this trick handy up your sleeves, do the BCCC. But counseling, I was embarrassed to have missed counseling in one of these early patients, and he was very bitter on me. Doctor, you didn't tell me plaque and the change in management.
Oh.
So tell all the options that you may end up to the patient, and make sure not only the patient but the relative, the younger son and the daughters understand that this is plan 1, plan 2, and likewise. It's very important.
Yeah, just a quick, any tips on the posterior capsulotomy, like central pull or whatever?
So, I mean, yeah, you want to try and pull it up towards the endothelium and towards the center most of the time, so that it doesn't extend. But like I said, some of these plaques can be very, very tenacious, and some points where it's impossible to bring them in with the forceps, and you may need your retinal scissors as well to try and cut these plaques. And
So
cut.
using both often works, like part
Yes,
cut, part
yes. So
pull.
you need, like Dr. Fogla said, like you need those forceps to try and grab the IOL. You also need vitreoretinal scissors handy, that if required you can just go in and cut those plaques there.
Excellent presentation.
So just one final slide. We would like to invite everyone of you sitting here to Ahmedabad for the 37th APS CRS, which is going to be held from 21st to 23rd August at the Mahatma Mandir Convention Center. Pretty much similar to what we are witnessing here, the kind of convention center. And please be our guests and please participate. It's coming to India after 12 years and only the second time that it's coming to India. So let's make it a grand success. Thank you once again to the entire faculty for coming and spending your time on this course, and thank you for the interaction with the audience. Thank you so much. Thank you.
Shay, let's take a photo.
Yes, yes, of course. Let's